anytime.
Okay. So I'd like to introduce Dr. Pam Baxter, who's an associate professor in the School of Nursing and also an associate member of the eHealth program. Dr. Baxter's primary research interests are nursing education, interprofessional collaboration, health service delivery, and leadership and management. So we look forward to hearing about that today.
Thank you so much. It's so much fun for Meredith and myself because we have never met in person, but we actually put a grant in together. So it's just so nice to put faces and names together. And I guess I better get over by where the microphone is. Thank you so much for having me here. I'm thrilled. I'm sure you're going, okay, what's a nurse meddling in some of these issues? And to tell you the truth, it's my background in both sociology and nursing that has brought me to this point. My PhD is actually in clinical decision making, and then I went into a program of research and interprofessional collaboration. And it was during my work in interprofessional collaboration that I realized, you know, you can have all the greatest initiatives and policies in the world, but unless you have strong leadership, you're not going to see the impact of those policies. And leadership played such a key role in interprofessional collaboration, which brought me into the area of leadership. So to this afternoon, I just want to cover 4 areas. First, I'll cover the background. Again, my focus, even though we're going to be talking about health policies and economics, my background is not in that. My focus will be on leadership, but I'll give you a bit of a broad context. Then review the pilot work that we've done in Ontario, which has been wonderful and exciting for us to see some of the findings there. And then we'll talk about the systematic review. And finally, I'd love to share with you the study that we submitted to CHR to the Partnerships for Health System Improvement competition. And so we'll be hearing about that at some point. So perspective is everything. I think it's really important for us to know and to look at issues from a variety of perspectives. You know, Henry Ford talked about this, needing to look at the other person's point of view. And I think you can clearly see that the perspective here is very different from the woman, from our perspective, and the fish. I personally think that she's part of the Plenty of Fish dating service, but that's just me. So just a little bit in terms of the broad context for you today. Across Canada, provinces are obviously seeking better ways of providing health care and to contain the ever-increasing health care costs. CIHI actually reported that the costs or the amount spent on health care funding last year, or in 2011, was $200 billion. 160 billion of that in public funds. Hi, come on in. Sorry. No problem at all. We are the last of the OECD countries that have actually adopted some type of funding reform, some type of patient-based funding, and we'll talk about defined patient-based funding in a little while. British Columbia, Alberta, and Ontario are the first 3 provinces to be implementing and adopting patient-based funding. The difference is that Alberta is primarily doing it in long-term care. So we're taking some of the lessons that BC have learned, and they've made a lot of strides in British Columbia. And Ontario, we'll talk a little bit more in a minute. So the drivers of the funding reform, I mean, it's no surprise that the Excellent Care for All Act has certainly had a big impact. And in particular, Bill 46, which talks about the responsibility of the healthcare organization to provide appropriate, efficient, effective, accountable, and safe care to the patients that enter into their organizations. And then, of course, the Mazankowski and Kirby healthcare reports, all suggesting pay for service is appropriate, and of course this criticism that this is perhaps one step closer to privatization in our healthcare system. So just a little bit closer to home, in 2012, April 2012, patient-based funding was introduced into Ontario, 91 Ontario hospitals. Not all of them were included. In fact, some of the smaller hospitals weren't included because it wasn't advantageous for them to be included based on the way they were going to do some of the calculations. So it represented a shift away from global budgets. And of course, you're well familiar with global budgets. That's a fixed amount that the organizations get yearly to cover their expenses. Funding now, patient-based funding, means that the funding now follows the patient. And again, we'll talk a little bit more about that. How much funding is received by each hospital is determined by the health-based allocation model, as well as quality-based procedures. So there's 2 actually ways of determining how much money is going to flow into the healthcare organization. So for you, if any of you are visual learners, you like diagrams, and I certainly do. And this is Michael Stewart, has been wonderful in working with us, actually. The Ministry of Health is one of our partners for the Partnership for Health System Integration grant that we've submitted. This is one of his slides that I've just adapted, and you can see the goal is that 70% of healthcare funding will be provided through patient-based funding. That's the goal. Currently, we're not there at all. Currently, we're about 30%, with 70% being global. Patient-based funding is divided into two components. First, the health-based allocation model, and secondly, the quality-based procedures. And in April 2012, they introduced 4 quality-based procedures. The first being total hip replacement, second knee replacement, cataract surgery, dialysis and other treatments for chronic disease management. So I'm just going to, briefly discuss the health-based allocation model. If I put up all the slides related to this, it would, well, may not blow you away, but it blows me away in terms of all the calculations that are done. But just to give you a general understanding of what we mean, the health-based allocation model is used by the ministry first to determine how much money is going to be given to the LHINs. In 2007, the LHINs were given the responsibility of funding the hospitals, CCACs, long-term care facilities, and so forth. In order for them to determine how much money came to each LHIN and the LHIN ultimately giving to the hospitals, they gathered direct measures of health status that included very basic measures, blood pressures, height, weight. They also considered population-based factors, as you can see here, age, gender, socioeconomic status, rural geography, and patient flows. This actually is a huge issue. When I was up in Thunder Bay talking to the leaders, this was something that came out loud and clear, was that rurality had a huge impact on the costs and the impact on patients and their families. Patient flows were also considered, and then provider characteristics. You can even appreciate that Hamilton Health Sciences, with its specialized areas, would require different funding amount than other smaller hospitals such as Woodstock General Hospital. They considered economies of scale. At the same time, even though they're talking about the larger hospitals having specialized programs, therefore they need more money, because of economies of scale, they actually are decreased in terms of their budget by 10% because they expect the systems all to be working together. I think that's kind of funny. If you've worked in a large corporation, because seldom do the systems ever align. Research and teaching a mission. Again, this came up, and we'll talk a little bit more about it. But research and teaching really does play a key role. But it's interesting, the teaching hospitals say, we need more money because we have all these students, and we have to support them. It takes us longer to do our procedures. And you've got the non-teaching hospitals that say, hey, wait a sec, we need more money. We don't have students that are helping us with all these procedures. So they each have their own perspective on how much they should get. So just looking at the patient-based, the quality-based procedures, we talked about the 4. And these are procedures that, based on expert panels, they've determined which procedures would actually allow them to generate or reduce the variation in practices. For instance, a total hip in Ontario could cost $3,696. In contrast, say that's in Toronto, in contrast, a total hip in Woodstock could be $4,000. So looking at, okay, why is there so much variation across the country? It's a total hip. How much variation can there be for that? And so that these groups identified these 4 key areas as being opportunities to improve services, to align services, and to reduce costs to the system. And what happens is every time a patient, and this is where the funding now follows the patient, so every time a patient has a total hip replacement, the hospital gets a certain amount of money, approximately $4,000. And the work I've done is primarily focused on orthopedic QBPs, so I'm going to be talking primarily to those. The reason why I chose orthopedic QBPs, number one, I had great connections in the orthopedic world, thanks to some wonderful colleagues. And secondly, because cataract surgery is fairly simple. We can identify fairly simply, and if you've had cataract surgery or a family member has had cataract surgery, they will comment on how efficient the system is. They can run through fairly quickly. They have them lined up, and they go 1, 2, 3, 4, and the volume is significant. With total hip replacement, there's variation. It's not as simple. People use different equipment, different cements, and all the rest of it. So I've tended to focus here. So every time a hip replacement is done, that amount is given to the organization. So you can appreciate what's the incentive. If they're getting $4,000 for a hip, what's your incentive?
Do it cheaper.
Absolutely, absolutely, do it cheaper. Because if I can do it for $3,000, I can bank and have a profit of $1,000. But you can appreciate there's some consequences that come up with that mentality, and that's where we're finding some very interesting information from the leaders. Okay. In order to measure how well the organizations are doing, organizations are expected to complete quarterly the quality scorecard for their area. Now, I've just put up the Orthopaedic Quality Scorecard. And you'll see that they have to report on efficiency, so the length of stay for that patient. So the length of stay, the average length of stay for a total hip replacement, what do you think it is? If you've had parents or grandparents or yourself have had a hip replacement, what would you expect it to be? 2 weeks. 2 weeks? Anybody else?
2 days.
Ah, okay, wow, that's a big variation. Eh? At 4.4 days is what the panel of experts has said when they looked at all the evidence of best practice. They said if it's done efficiently and we do everything effectively, it should be 4.4 days. So that's the target, is 4.4 days, and so everybody reports how close to the target they came, and they keep track of that quarterly. The other expectation is that 90% of the patients are discharged home. Now you can appreciate in 4.4 days and 90% have to be discharged home that there are issues that can rise from that. Issues for the patient, issues for the family, issues for the receivers in the community, the rehab specialists that are out there and have to see them within 24 hours. So there are other issues there. They also have to report on the rate of readmissions. It's great if you get them out the door, but if they come right back in, that's a problem because you don't have funding for that. You were funded for that operation, you were not funded for them just to come back in. And the rate of revision within 365 days, so we expect it to be quality care as well, which is one of the goals. And then the other issue they have to report on is accessibility and the wait times. Of course, you understand the wait time policy has been in place for several years now. So they do look at wait times and how quickly, and this is one of the intentions, was to reduce the number of days that they were waiting for their hip replacement. Right now, they expect you to be seen and have your surgery within 182 days. Which is not too bad, unless you're walking around with a sore hip, and I'm sure 182 days seems like a long time. So the goals of PBF are to provide equitable share of the funds that are available. And this is where the HBAM comes in. It determines that equitable distribution of funds. It promotes evidence-based decision making. It provides incentive for higher quality care and more efficient care. To contain costs, to promote fairness. We talked about equitable distribution of funds, timely access. This is the other piece of it. It was to promote innovation in care delivery models. And this is what I found very interesting. I'll talk a little bit about that in a few minutes. And then to improve hospital productivity. So, the Ontario Ministry of Health actually talked about the role of leaders. And they said that leaders must show a commitment to the goals of PBF. And in order for it to be implemented successfully. So that provides you a bit of context. Are there any burning questions that you have right now before I go into the next step, which is talking about where we came from?
I'm interested in all the population factors of the HBAM. Do you know how they came up with those particular ones, or how they value each one, or establish thresholds, or how they sort of generated that list?
That is an entire other presentation,
okay.
But I can provide you with the resources that show exactly how that's broken down and where they got the data from. Some of it came from the 2007 there's a patient survey where they gathered some of those actual measures such as blood pressure, visits to the doctor, and all the rest of it. So there were other databases that they accessed for that through Hi. But I can provide that to you, Meredith. Thanks. At our next meeting. Oh, look at that. It started all over again.
Oh, sorry.
They don't want to listen to me again. Okay, now that could have been me. So.
No, that was me, actually. I had to do something that I didn't do in the beginning.
That's okay. Here's a quick review.
Pleasure, dear.
Anyone
Yes.
there with me? So how in the world did I get interested and I always want to do research that makes a difference. I don't know about you. I'm not interested in doing research for research's sake. I'm sure there are people that do that. But for me, I guess it's the practical side of me that comes with the profession. That is all about giving. It came from actually a coffee. I sat down with a colleague of mine and friend, and she said, Pam, you need to be looking at this issue of the introduction of the orthopedic quality-based procedures, because we're very excited, and I'm going to hide everybody's identity in this presentation, but she said, we're doing some very exciting and innovative things as a result of patient-based funding being introduced. We knew it was coming down the pike, I never get that right. It was coming down, and I knew it was coming down, so we actually were proactive. We set up a steering committee, we did A, B, C, which is wonderful. We're seeing great results, but we're also having many challenges. I went, that's great. Well, if you're having challenges, it's important for me to look and see if others are having the same issues. So we went to the Ontario Health Human Resource Research Network. I think that's chaired by Ivy Bourgeot, who is one part of our research team. And she is now, she wasn't then. And then the CIHR meeting grants. And we were able to get funds to facilitate a variety of meetings across the province. We accessed and were able to gather data from 5 different LINs, 70 healthcare leaders, I'm talking senior executives and orthopedic surgeons. We found that they were very important to include. And the purpose was for them to discuss their experiences with the implementation process, because it became clear that there were issues that needed to be addressed. Several themes emerged from it: responding to the change, leading the change, and managing the change. And within each of those barriers were described. And I'm not going to give you all of the findings. We actually have a paper that's just being submitted. But I'll give you some ideas. These are quotes from some of these meetings that we had. Changes were necessary. This is a general theme that came through. Nobody wanted to go back to the global budget. They all recognized it was not sustainable. So they said it was necessary, and it's forced stakeholders to think about their current practices and to consider alternatives. They talked about, now we ask, why are we doing it this way? Why are we using that piece of equipment? What can we do differently? This was a common reaction. The bomb is dropped and we're picking up the pieces. This came from a senior administrator. The only thing stopping it from blowing up was our buy-in to the mission and vision. I think that's a very important point. They're saying that wait times are rising, but we're doing all these things to help, but our ORs are closed, so what's our incentive? This is a big issue, especially in smaller community hospitals, because remember, HBAM determined how many quality-based procedures that the hospital gets. So if you're only allotted 50 hip replacements in a month, then once you're done that, you're not getting any more money if you do additional ones. So there were issues for them, and they said that some of the orthopedic surgeons didn't want to stay anymore because they weren't doing enough surgeries. So the orthopedic surgeons weren't pleased as well. So difficult and challenging overall. Committed to it, but there were definitely difficulties and challenges. Then they talked about leading the change. They found it difficult in general to lead the change when they didn't have the communication that they felt was necessary during the planning phases. They recognized, and in their initial response to it, was that it was difficult to lead the change and convince the other stakeholders in the organization that this had value for the patient when they saw this as cost containment and not necessarily about quality of care. And that resonated through all discussions. Patient-centered piece goes by with this funding approach. There's a general lack of organizational preparedness, so leading the change was difficult. And they talk about the timing. The only time we got information, other than 2 days before we were to implement or something like that, very little time. So we had quality-based procedures, and we had just seen the list, and we had no idea what was going on. A little frightening when you think that we're talking millions and millions of dollars, and how these senior leaders were responding to it. So in terms of managing the change, participants talked about the ability, they said, you know, it's here now and we're going to make the best of it. We're going to be as efficient and effective as we can. They talked about some of the interventions and decisions they've made. They developed standardized plans for care, standardized orders and pathways. They talked about standardizing equipment, simple things like agreeing on a cement because of their ability to order larger amounts and not every orthopedic surgeon having their own specific cement. It greatly benefited. So they looked at the best evidence and found what was the best, and they all agreed to use it. The development of new roles. Some hospitals talked about the role of the navigator and being able to use a navigator to propel the patient through the system, keep them informed, help them to understand why they're being sent home or why their mom or grandma is being sent home after 4.4 days. You can appreciate it. The public doesn't understand this. First of all, if the healthcare providers and leaders don't understand it, how do we help the public understand that? So people had talked about the development of this role and communication pathways. This became evident, and it is in the literature when you look at patient-based funding globally, the issue of cherry picking. Again, if we are going to try and generate some profit here, we want the best patients to come through the door. We want those patients that don't have comorbidities. Who do you think this impacts significantly? What group of the population? What group would have other things wrong with them?
Lower income.
Lower income, very good. So those low income areas would have patients that would have maybe other things, other disease processes. Who else? A big majority. The elderly. The elderly. So some of the leaders recognize that there is a real tendency to pick those. Here, one leader talks about obliged to treat the healthiest of that category because you'll get more funding, and that's counterintuitive to pushing those patients out in the community. I want to bring those patients in. There was a real conflict between them understanding this was cost containment and that needed to happen, and being committed to the patient. Managing the changes effectively and seeing positive results included reducing lengths of stay and greater efficiency, so they were seeing some benefits to it. And then finally, this was another issue in terms of managing the change, decision support. Can you imagine the amount of data that the healthcare leaders have to collect for every single patient PBF? Sorry, every QBP. So for every QBP, and this is just the beginning, there are many more that are just being introduced. So this is just the beginning. Remember, we're only at 30%, we're going to 70%. So they talked about the need for decision support team. This was a large hospital. They had the mechanisms in place. They weren't concerned. I think I had one down, I had another quote. Don't see it right here. And it talked from a smaller hospital and the perspective that they had, they just didn't have the support system there. They didn't have the human resources to say, okay, you're going to help us. They didn't have the knowledge and expertise, and they didn't have the funds to train people to do what needed or to hire people that were competent in that area. So what did we find overall in terms of this local group in Ontario, the 5 months? What did we find? Well, we found that strong leadership is obviously required to implement patient-based funding, particularly quality-based procedures. They need strong support and an infrastructure that's available there. And looking at organizations, say, okay, what do we have available? How can we either enhance that or change that so that we can meet the needs of this funding approach? Leaders need to have reliable, accurate data, and that comes down to the physicians and the other healthcare providers. And they needed real-time data. I don't know how much you're familiar. In the hospitals, they have picker data, and that's patient satisfaction data, but they would get that several weeks, if not months, after the patients have been there. And they talked about the need to have real-time data. And leaders are beginning to see the benefits associated with PBF, which I think was very important. If they don't see the benefits, then you're going to have an upheaval, an uprisal against it. And leaders are facing significant challenges. So, okay, now we know that leaders are key to implementation. So what's the next step? For us as a team, it was going to the literature and seeing what was out there. So we got some money and did the systematic review of the literature, looking at the experiences of implementing patient-based funding. And Our aim was to gain a better understanding of the experiences of healthcare leaders implementing patient-based funding in acute care settings with OECD countries. And we defined healthcare leader, and this is difficult. They just, having people identify themselves as a healthcare leader, it's such a broad term. We used Newland's definition: an individual who creates vision and goals, mobilizes and manages resources to produce a service, change, or product consistent with their vision and mission. So I won't go through all the key terms, but I thought this is good, especially for students. You know, if you're interested in this, even to get all the key terms that are associated with patient-based funding, and there are many, and every country calls it something slightly different, and you can see here. We did have Laura Banfield and another librarian from the University of Alberta help us with this search, and Sarah Hugo from University of Alberta was very helpful with this, to provide us with the key terms and to conduct the searches for us using these databases. And we covered the periods of 1982 to 2013. The reason being, in 1983 was the first year that diagnostic-related groups were introduced in the United States. So our inclusion and exclusion criteria, again, I'm not, nor do I have the time to go into all the specifics, but again, for you students, it's good to have this up there. We did extract the data using, looking for these elements. 2 individuals extracted the data, and then a third author actually confirmed those extractions. And here are our results. We found over 15,000 references to the patient-based funding and leaders. When we had taken out the duplicates and we had reviewed the abstracts and titles, we came down to 22 manuscripts that we reviewed fully and determined the quality. Ultimately, we were left with 14 articles. So again, I certainly didn't want to put all the characteristic tables in here. This paper is being submitted to Health Policy, so we're just waiting to hear back on that. All of the papers were published between 1998 and 2011, the majority of them in the last 5 years. Of the 14 articles, 12 were actually qualitative, and 2 of them were mixed methods, where they had the quant and the qual mixed. In terms of the qualitative, 2 used grounded theory, and 2 used case study. One of them was actually a multiple case study. My background is case study. I love case study methods. If anybody's taken my course, you know I'm very, very passionate about case study because it allows me to bring in data from a variety of sources and converge it to understand the phenomenon. And then the others just described as general qualitative methods. They talked about just doing interviews or focus groups, but never actually identified a design. And all of them always can examine some form of prospective payment system, or PBF. And you can see the breakdown here. The United States, 10, they used terms of patient pay for performance and diagnostic-related groups interchangeably. England, 1, United Kingdom, 1, Sweden, and Germany. So 7 of the 14 studies, when we examined them for quality, using 2 different tools, one for the qualitative studies, one for the quantitative studies, we found that they were low, half of them, and half of them only achieved a score of medium. Tons of methodological limitations in these papers. Now, we have to say that may be due to the lack of space provided to them, and so therefore some of them just did not rate as high as we would like to. Here is a summary of the thematic results, and you can see that the majority of them focus on the prerequisites for success, and the other big area are the barriers and challenges. And I'm just looking at my time, so I'm going to go through and give you as much as I can in the next 10 minutes, and then we'll just go briefly through the studies. That sound okay? Okay, so in terms of the prerequisites for success, the articles talked about 2 different types of prerequisites. First was, this is through thematic analysis that we did, creating matrices, and then again the quality analysis was done independently by 2 different people. Prerequisites for success, first organizational factors, and I'm going to keep looking down here because I don't have all of these in memorized in terms of the number of articles. Organizational factors. The biggest one that they talked about was the need for the organization to be committed to and supportive of patient-based funding, which is not surprising. And actually organizing it as a strategy to achieve better quality. They also talked about the need for infrastructure, which is reflective of what we heard from the pilot work. They said infrastructure needed to be there to support the various individuals and activities to accurately measure quality, including upgraded IT systems. This is another issue, that the systems, the IT systems weren't in place in the pilot. And the systems that were capable of producing and tracking and aggregating data. And they also talked about the need for organizations to ensure that they had leaders that were moral and ethical in their practices. And then in terms of the individual factors, they talked about committed leaders who are supportive again of the funding changes and recognize the benefits, the potential benefits, and who are willing to put the time in to implement it. There was an additional administrative time that one of the articles talked about, and they said it needs to be recognized that this takes a ton of administrative time to do. I'm going to skip us down to the barriers and challenges. 10 of the studies, if you go through, actually talk about the different barriers. And it's not surprising, 11 of the 14 talked about barriers in general. 10 of them talked about the negative impact on resources. And 6 addressed the negative impact on human resources. And I think that was a significant finding from the review. They talked about laying off of staff, the need to hire additional staff, additional workload for care providers. We've actually submitted another grant that looks at how patient-based funding and quality-based procedures are impacting registered nurses. Because we've had nurses come up to us and say, are you going to include us in this study, because we have a lot to say about workload in terms of the change. You can imagine if we're basing it on volumes in the OR, you're putting through a lot of patients, and that impacts an OR nurse that stands for 9-10 hours working alongside a surgeon. Inadequate number of experienced nurses and coders to perform data collection was identified. The inability to mobilize existing individuals to other areas in order to implement PBF, and a lack of funding to train the staff to understand what is needed and to support the implementation efforts. And one study just simply said poor software. And then the other barrier is just in terms of implementing and evaluating. And this all had to do with data, accessing data, getting accurate data, being able to record and aggregate the data, and then report it back. So they talked about 11 of the 14 studies talked about barriers and challenges, and 10 of them talked about the lack of resources, in contrast to 7 that talked about implementation barriers. And the burden of data collection. And like I say, if they're talking about burden in Canada, in Ontario, we're going to face significant barriers as the demands increase, as new QBPs are introduced. And then they talked about commitment factors. 6 described a lack of leader commitment as the barrier, and this was related to skepticism, a suspicion about its ability to improve healthcare, a suspicion about its ability to contain costs and to produce business benefits, and suspicion about whether or not it actually does increase efficiency. And then unintended consequences. Again, we talked that for us, we found that there were unintended consequences. The big one, again, was talking about gaming behaviors. So upcoding was one thing they talked about, and cherry picking, just as we heard from the healthcare leaders in Ontario. And concealing and manipulating data. You can imagine the pressure, because these are posted, these are public. So you can see quality scorecards for the limb, and you can imagine there's pressure from your other organizations, pressure to do better, and not to look like you're lagging behind or you're not performing as effectively. And then they made some recommendations, and 6 described recommendations for leaders charged with implementing funding changes, and they were directed at the organization and the program unit levels. And at the organization level, 5 described the need to garner support for the funding change from the top down, include administrators, which seems obvious. And they said the importance of including physicians right from the get-go, and to actually utilize the physicians as change drivers, because without the physicians and the orthopedic surgeons, nothing's going to work, right? And we certainly heard that from the focus groups. And then to include clinicians and staff. And from our pilot work, we saw that the senior administrators were there and the physicians were there, and some of the program directors, but very few staff were involved. And then providing additional resources for the training of staff was talked about as a recommendation, and increasing collaboration and cooperation with other units and project groups to be more efficient, and then increase interprofessional communication and interaction, and the sharing of data, personnel, protocols, so just more collaboration in general to ensure that there was efficiency. So what did we conclude? PBF is a complex process involving many stakeholders and requiring deep commitment from all those involved. It demands a number of resources to gather, interpret, and report quality data. And when implementing, leaders need to be mindful of the potential for unintended consequences and put strategies in place to curtail them early. And methodologically rigorous research is needed to explore leaders' experiences of implementing PBF in relation to PBPs. So, in terms of policy implementation, we feel that policies are needed to address the unintended consequences associated with PBF, and are also needed to promote ethical, accountable practice, and policies are needed to support leaders to mobilize existing personnel during PBF implementation and to hire or reassign staff to meet the heightened demand for data collection. So what was our next step? Well, based on the systematic review identifying that there are issues, but it's not being fully explored, and it's not being explored using rigorous methods, we decided to propose a study, using a mixed method sequential design. The phase 1 that we've proposed to CIHR and the Partnership for Health System Improvement Grant is a provincial study of all their healthcare leaders in acute care settings on implementation practices related to PBF and QBPs. And we have a large team. We've been making strides, and this is why the meetings were so important, is because they're so busy with the implementation that we fear that we're going to have difficulty. But we have gotten buy-in, tremendous buy-in across the province for this. So after the survey is done and we understand what some of the outcomes are being achieved, what their implementation practices are, then we're going to conduct a multiple case study. Can you imagine why? I wish Jaime was here because he's taken my course. But can you understand why we would do a multiple case study based on some of the comments we've just made in terms of the impact on different types of hospitals? I'll just take a guess. There's food out there. What we're looking at is we know that the smaller rural hospitals have many more challenges and different types of challenges than the larger teaching hospitals and the large urban centers. So what we're going to do is do a case from each of those two, and we'll replicate those case studies to see if what we're finding is consistent. And then finally, we're going to develop an implementation framework for healthcare leaders. And this is something that the ministry is so excited about, and they are our funding partner for this. So that is our next step. And I don't want to go through all this, but these are the goals. I'm just looking at my 4 minutes left. These are the goals. And you can see that one of them is to provide information to policy and decision makers in the form of a formative evaluation of the process used by Ontario healthcare leaders to promote consistent orthopedic care. One of the things that we're going to be doing and asking, and I've got a slide with some of our questions, is what innovative care delivery models have you actually developed as a result of patient-based funding and quality-based procedures, and to then have a repository, and then from there start to develop a best practice in terms of care delivery for orthopedics. And to promote the development of leadership capabilities, we'll be using the Pan-Canadian Leadership Capabilities Framework to guide us, along with the logic model for this project. And also to guide future QBP implementation efforts. As you know, there's only 2 provinces that are currently using PBF, in acute care settings, and others are looking at it and piloting a few things. But certainly we're not there as a country yet in terms of overall patient-based funding adoption. And then to inform ongoing PBF and QBP policy development to better define the role of the healthcare leader in PBF and QBP implementation. That's not out there in any of the literature that we've found so far. It's looking specifically at the role of the leader and what they're required to do to successfully implement. Again, I'm not going to go through all of these, but I will make the slides available for you, again, for students. I want you to see the different types of questions that I'm posing for the different phases. Especially case study, we ask a lot of hows and whys. It really focuses on process. And so you can see with our multiple case study, we're going to look a lot at the hows. How barriers have impacted the implementation, how innovative care models have been developed, how contextual factors have implemented the implementation, and so forth. So any questions? Look at that, we have 2 extra minutes. Whirlwind, blank stares, smiles, which are lovely, I appreciate that. Any questions?
I just have a sort of clarification question.
Yeah.
So the purpose of the systematic review is to identify certain themes,
Yeah.
is that correct? But you did mention, I think you mentioned doing a quality assessment
Yeah.
with a couple of people. So I'm just wondering, did you use a standardized tool
yes.
for quality assessment?
Yes, so let me just grab my notes for the
you
name
just
of the
comment
different
on that.
ones. Yep. The one that we used for the qualitative ones were Letts, Wilkins, Law, Stewart, Botch, and Westmoreland. That's probably why I didn't get it all off. It's the critical review form for qualitative studies. That's actually available online. So we use that, and we used an adapted version of Cummings' tool. She did a paper in 2008, and we used that for the quantitative. The quantitative were so descriptive. They didn't fit necessarily with specifically looking at a randomized. Nothing was randomized control or case control or anything like that. So those were the tools that we used.
Thanks.
Students, questions? Nothing? No questions?
I'm kind of interested in the composition of your team for this work.
Yes.
It sounds like you have a lot of people on board, but also a lot of different areas of expertise that you'll need.
Mm-hmm. We have a team that consists of myself, Greta Cummings, who has a PhD, well, she has a large program of research in the area of leadership. We have Dr. Rick Hackett from business, and he focuses a lot on leadership capabilities. We have orthopedic surgeons, Dr. Higgins from Sunnybrook that is with us as well. We have ministry partners that are part of this. We have several VPs of different areas, patient services. There's, in total, I think we have, with our decision makers, probably 20 on the team. The reason why we had to be broad, as you can appreciate, that we need, Dr. Colleen McKee is on the team. Deborah Kennedy, who's a rehab specialist at Sunnybrook Hospital, is part of it. Yeah, and several, like there are a couple of orthopedic surgeons. We have an advisory committee as well that we set up. But what's so important, especially with Partnership for Health System Improvement grants, I mean, you have to actually raise, I think it's 40% of your overall budget from another partner. So first we had to get that money and secure that, and we were successful in that. And a lot of time and effort goes into establishing these relationships. And if you think research isn't about relationships, you're absolutely wrong. And you stand in here, I stand in front of you, and each one of you should be thinking, how can we connect? In what way? There's got to be some way that we can connect, because my resources become your resources. I can help in different areas that you may never have considered. Networking is so important. And if you haven't taken anything on networking, please learn to do it, because it makes your research so much more enjoyable to do. But also you can disseminate so easily when you have the right people already on board, and certainly makes your writing of the grant so much more easy as well. But when I go to recruit, guess what I'm going to be drawing on? All those people that I went to during the meetings, I have their personal emails, and so for recruitment purposes, that really will be helpful, especially in a tough area like this.
So on that note of having a network, so the proposed multi-site case study, I think you said 4 to 6 cases. So do you already have an idea, because I think you mentioned you have rural ones and then maybe specialized centers, so do you have those kind of set up already?
We don't because we're waiting for the results from the surveys.
Okay.
The surveys will help us to identify, what hospitals have given us information. Have they implemented innovative care delivery models? Are they dealing with certain challenges? So we're waiting for the survey data. It will dictate then our sampling strategy for those cases.
Okay,
yeah.
Thanks.
Yes.
I was wondering, as far as the quality-based procedures, and you're trying to increase that list, can you talk a little bit about that, about those challenges? Because I know there's a lot of literature around how evidence-based medicine can't say which procedure is better than the other, because it's better for some populations and worse for others, so there's a lot of gray area there.
I'm glad you brought that up. I just want to be clear. I don't want to increase quality-based procedures. It's the ministry that we need to, right? And it's just to increase efficiency and services. But I think there is a lot of gray area. I think there is trust. There's a lot of trust. Like the orthopedic expert panel was developed here, and they informed the development of the 2 quality-based procedures for orthopedics. So I think there is a lot of trust that goes into that panel. Now, when talking with orthopedic surgeons out in Ontario, they felt that they hadn't been included enough in the development of that. And so I would say, in terms of the policy development, to have even more people on board would have been better, but I understand you're constrained by time and money and the availability of these orthopedic surgeons that are extremely busy, and other senior administrators. But your point is well taken. Tons of gray area in terms of best evidence and best practice.
Yeah, what do you look at as quality? Is it just the clinical outcomes, or is it patient satisfaction?
Well, exactly, and that's the piece that actually is a concern, is where's the patient satisfaction piece. I believe there's a survey out right now looking at patient satisfaction. We were actually discouraged from doing patient satisfaction in this study. We had it in, and we took it out based on feedback from the ministry that they were taking care of that patient satisfaction piece. So that information will come out, I would assume, in the next couple of years. Yes?
There are a few things in your in this system that reminded me that how they changed the physicians are being paid too. I mean, they're instead of fee for service now, they're the trend is just getting them roster day patients more. But I mean, the difference, if I understand it correctly, is that they can determine the patients. I mean, like there's a characteristic of patients that how much it will be each patient for each patient. The ministry will pay to the physician. But in here, I think it's a little bit more restrictive, saying that ministry says that you have only this many patients in your area, and more than 50, for example, hip replacements, I'm not going to pay. But I mean, what if I have more demand in one month versus the other? It's just going to, or 1 year versus the other. It doesn't really recognize that. Like, I mean, there are some loopholes in this current I don't know, scheme of doing things.
No, you're absolutely right. And then does that require people, say in Hamilton, to go to Burlington, Halton CCAC for their surgeries? And I think that's something that they're continuing to explore. So if the demand is so much greater, I think they feel confident in the numbers that they have given to the hospitals. But the feedback from just our pilot work was concern for that. I'm not sure how flexible it is.
Because, I mean, like, we are talking about Ontario, it also has lots of inflow of people too, right?
Sorry?
Inflow of people, like immigrants, and it's like, I mean, these numbers do change, they're dynamics, they're not static.
And that's something I would take back to the minister's question, because I don't have the answer to that.
Yeah, and I know a little bit literature on this too, that's why that 4.4 days is very, I know it's just the average of something, but it also matters when you kind of accept the patient in the hospital, because the weekend discharges are difficult, because a discharge needs a physician, and physician may not be present on the weekend. So maybe, I'm just guessing, I would be suspicious. I'm economist background, so that's why I'm suspicious. I mean, maybe the hospitals are more inclined to accept these hip replacement patients on Mondays and Tuesdays. But past Wednesday, no, you're going to stay on the weekend, no.
But you know what? You bring up a very important point, and they are considering things like that. They are considering, can we send this person out? Is there somebody in the community to receive them on the weekend? Is there a CCAC case manager, rehab therapist that's going to be able to visit? There's all sorts of things, and this is where they, you know, do they change then the admission date? Do they wait until Monday to admit? This is all happening as we speak.
Unfortunately, people are like me.
Yeah. But your brain is exactly what some of the issues are in the literature and what we heard. So many juicy issues with that. Gaming, you know, the app coding. So, you know, the ethics of this. In terms of policy, guys, there's so much in here. It is so meaty. I get so excited. You know, because it's an entire program of research that could last for years and years. It's one thing to look at a hip replacement. It's something very different when we get into different cancers and cancer treatment and some of these other complex issues. Is it reasonable to expect that we can actually find best evidence to support a specific number of days? The other thing is this is just gathering the mounds and mounds and mounds of data and then interpreting that data and recording it back in an accurate way is just, it's overwhelming, I think, for many of them. And that's what they're saying. What happens when we have 100 of these?
Yeah.
Is it reasonable to expect?
One of the really meaty issues that that grabbed my imagination was this idea of what patient populations are being pushed aside, or who are, you know, who are not going to have probably the best outcomes, and so what happens to them, and where do they go? Do they get care? Do you have scope in your project to explore that? I know you always have to make decisions about what you can and can't do with the time and the resources available.
The piece, that's a great question, Meredith. The piece that we'll get that type of data in will be in the interviews. That we can, you know, add a question to say, okay, how do you feel that this is impacting vulnerable populations? There's literature out there that talks about, there's only a couple from the United States that said that this is really hurting the minorities and the vulnerable populations as well. Yeah.
Even people with other chronic diseases like diabetes or something that makes their tissue less, you know, it's just harder to operate on someone who has long-term diabetes. So it's all kinds of people that might get pushed aside.
Now I want you to understand the complexity of it, because they're different, because they do certain calculations. They will put in that somebody has diabetes, so they may have,
they can accommodate that sort of.
Well, and there's going to be somebody that comes in and they're home in 2 days. Actually, because of the discharge, there's actually been some research that showed that they were discharging to a hotel as home, not into their own home, but it kept their numbers down. Like, there's all sorts of gaming that happens, and it's just fascinating to see. Well, it's cheaper, but they also got to record that they were being discharged, right? So it didn't matter where they were discharged. The other issue is one article in the systematic review talks about the impact on the families. And nobody is looking at the impact of this on the families, because if you think of who's the population that generally gets a total hip replacement, those are the 50 to 80-year-olds. Oh, I'm just pulling that out, okay, out of here. but to me, that's who would have a total hip replacement. And you think of those children. Well, children of the 80-year-olds are my age, right? And we're all working full-time, generally speaking. And so the impact of those discharges on the family are significant, can cause a lot of strain. And then you have to consider your healthcare providers, who should be made aware of what's going on. I will hazard to tell you that the nurses on the floors just see the push them up, push them up, push them up, push them up, and don't actually understand, because there's no money for the education, why this is happening. What does this mean? How can they help and be part of it? So that's why we have another granted to the Ministry of Health right now to look at the roles and what role they could play, actually, in helping ensure that the targets are met.
Are you going to look at the patient's point of view?
Well, we had a lot of discussion about that, but again, it's whether we want to open that up or not. We actually had a patient advocate on the team with us, and we can add the patient perspective if we feel that we have the luxury of the time and the money to do that, or maybe just a separate study, just to do it full
curious
justice.
about, like, I mean, what kind of attitude they get when they try to, like, complain about their condition to readmission. I mean, like, how is it to be readmitted? I mean, if they're really suffering, for sure the hospital cannot refuse.
Oh, no, 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 no. They'd still come in.
Yeah.
And remember, this is only 70%. The ultimate goal is 70% of the full budget for the hospitals is provided through patient-based funding.
Mhm.
There is still a steady state. There's still partial global budget there,
Yes.
right? So you still have 30% of the global budget. But all they'll see is that it's chipping away. If they are readmitted, it chips away at some of those reserves that they would like to put to other places. This is so interesting, guys. Like, I don't know if you've picked an area of interest, but this is one that is just, it's very interesting. I think this is a huge change for the Canadian healthcare system. It's definitely for Ontario. We need to be thinking ahead of this. Is this a slippery slope towards privatization? And just, I want this to be on your radar. I want you to look at this, and maybe the next time you're talking to somebody, you look at this issue with a different lens on, a different perspective, and just give it a little bit of thought. And I don't know what your areas, again, are for research, but anyway, hopefully I've stimulated your thinking today. Okay, thank you very much.
Sure.
Thank you.